Let's move now to Barrett. Most of you know that Pradeep Bhandari instructed the endoscopy community here in Europe in detecting visible lesion in Barrett metaplasia. Before Pradeep, we were very, very bad. The next step for Pradeep career is probably to move from AA, acetic acid, to AI, artificial intelligence. Please, Pradeep.
Hi, morning, everyone. It's a real pleasure to join such a distinguished group of people early in the morning here in UK. AI is the future, I think, but it will not replace us, but will definitely help us. So let's go ahead with my talk and then we can have a discussion. Hello. My name is Pradeep Bhandari. I'm a gastroenterologist based in Portsmouth, UK. I would like to thank Professor Inouye and his team to invite me to take part in this fantastic event. I'm really honored to be part of this prestigious event and would also like to extend my gratitude to NEC for sponsoring this special satellite symposium. Now let me share my screen with you. I hope you can see that the topic for my talk today is artificial intelligence in endoscopy, but I'll be focusing primarily on Barrett's neoplasia and sizing during endoscopy. These are my conflicts. As I said, I'll focus on Barrett's and AI, as well as polyp sizing and AI, and broadly discuss these topics under the question of, do we need the help from AI? How can AI help? And where are we with AI? So let's address the question about the need for AI in Barrett's neoplasia. This is the data which shows that 11% of upper GI cancers are being missed during gastroscopy. So that amounts to about 1 in every 398 OGDs we miss a cancer. Now, some of us might say this is might not be Barrett's, but look at the Barrett's data. Here you can see that the patients which were referred from primary or non-academic centers to academic centers for treatment of Barrett's neoplasia, what the experts at that center found that 76% of the neoplasia was not visible to the referring doctors, but were visible to the experts at these academic centers. So again, there is a large number of Barrett's neoplasia which are potentially being missed. If you can look at these two videos, it'll give you an idea why we miss Barrett's neoplasia. On the left side, you can see a little abnormal area on the top of the gastric fold. But I'll show you when you use acetic acid, and here when you use BLI on the right side, how we can find a very, very subtle neoplasia which was not otherwise obvious. You can see on both sides I've circled that this Barrett's neoplasia was not obvious on white light, but when we use these enhanced modalities, and if you know what you're looking for, it is possible to detect these neoplasias. Unfortunately, they're very subtle, very easy to miss. And I feel that the current management protocol, again, is very, is not perfect. You can see here, because of this, about 15 to 20% of the Barrett's neoplasia is being missed because we have a blind biopsy-driven protocol, and the adherence to this protocol has also been found to be very poor. ASG is recently in their new guidelines have recommended that Seattle protocol-guided biopsy alone is not enough, and they're recommending chroma endoscopy on top of that, or Watts 3D on top of that, because that leads to an absolute increase of 9 to 10% in detection rate for neoplasia. Now, how can AI help in detecting these Barrett's neoplasia? Well, to start with, AI can help in detecting the Barrett's and measuring the length of Barrett's. AI can help us find the neoplasia and help us localize the neoplasia. It can delineate the margins of the neoplasia. And finally, AI can also help in characterizing and staging the neoplasia. Uh, where are we right now at this stage? I think most of us are at the moment focusing on detecting neoplasia, localizing neoplasia, and delineating the margins of neoplasia. This is some of the data from US in a small study with 26 dysplastic Barretts and 13 non-dysplastic Barretts. AI sensitivity was reported around 96.4% with a specificity of 94%. Here you can see on the right side, sorry about that, that within the bounding box, there is a Barrett's neoplastic lesion. Similarly, this is a study from Jack Bergman's group in Amsterdam with another small sample, again found a high sensitivity of 90% with a specificity of 70%. This is another study by Professor Messman's group. Again, in a small number of patients, they found a sensitivity around 83.7% with a very high specificity and accuracy. So it looks like we're making progress in detecting Barrett's. These are small studies from few of the groups around Europe and US. And this is our experience at Portsmouth. We've been working with NEC, and in collaboration, we have been working on developing an engine, and the latest results of this Barrett's AI engine, which was tested on 107 images from neoplastic Barrett's and 364 images from non-neoplastic Barrett's. What we found was our sensitivity at around 96.3% with a specificity of 97 and a very high accuracy rate. So this looks quite a very impressive data. We are also working on segmentation to identify the exact location of Barrett's neoplasia. I won't go into the details, but the data looks good. We also figured out the processing speed of how fast AI detects these lesions. And on a binary classification, the detection rate was only 5 milliseconds per image. When we ask AI to do the delineation for us, then it takes a little bit longer to about 33 milliseconds. But if you compare this to human detection and delineation, it takes about 70 to 100 milliseconds. So it's obvious that AI detects very fast, delineates much faster than human eye can do. These are some of the examples. You can see on the left side a large Barrett's neoplasia, and here's AI heat map showing exact location of this Barrett's neoplasia. Another example, there is a slightly depressed Barrett's neoplastic lesion there, and heat map shows where exactly it is. This is in the red bounding box is the manual annotation done by myself, and this is the delineation performed by the AI engine of the same lesion. Again, another example, red is the bounding box drawn by me, and in the blue shadow, you see what AI is delineating the lesion. So you can see that AI is detecting and delineating very well. Another example of a very, very subtle Barrett's lesion. Again, it finds it and delineates it. Here is a video illustrating the same aim in action. There's a lesion at 6 o'clock. When we move away, it doesn't detect. As you get closer and closer, the heat map is showing exact location. I go past it and it disappears. Again, I come back to it and you see the heat map shows exactly where it is. Very, very accurate localization. Another lesion case, this is the lesion with a depressed lesion. You'll see as I move back and show that area, if the heat map will show you again. I move away, it disappears. Let's get back to it here. Heat map shows the exact location of it there at the bottom. But actually, when we used the AI, we found that there was not just one, but two lesions. See, I go down and there's a second lesion there. And again, heat map shows the exact location of this lesion. So these are very subtle lesions, two lesions very close to each other, and AI found both of them and delineated it very accurately for us. This is just an example, a recent study we published where we compared targeted biopsies with acetic acid versus Seattle protocol-guided biopsies. And what we found was that this targeted biopsy results in almost tenfold reduction in the number of biopsies we take during Barrett surveillance, which despite having a very high false positive rate, acetic acid still showed a huge reduction in the number of biopsies, resulting in a huge reduction in the amount of money it costed for the histology processing of those biopsies. You can see from 125,000 to 13,000. And imagine this is just in 190 patients with the UK Barrett's prevalence of 375,000 patients. The amount of money that we can save by targeted biopsy will be huge. And if we can prove this with AI, then this will pay for itself. So in conclusion, I feel that AI will not replace the endoscopist. We'll still need them to make the management decisions. But there's a real possibility that endoscopists using AI will outperform those who are not using AI. I feel that AI can act as an expert second observer to improve the performance and outcome of the procedure. It will also reduce the number of biopsies and the procedure time, making it very cost effective. And I feel in future AI will accurately stage the neoplasia and help us make the right decision for the management of Barrett's neoplasia. Moving on to sizing of neoplasia, as we are all aware that there are a lot of guidelines which are based on size of polyps, the size of neoplasia in polyps. We talk about resect and discarding strategy of polyps under 5 millimeter. Again, we talk about hyperplastic polyp less than 5 millimeter, which can be left behind. Carcinoids, we have a cutoff around 10 millimeters. Less than 10 for type 3, we can do resection. For carcinoids type 1 and 2, less than 20 is the cutoff. Gastric gist, again, the cutoff is around 30 millimeters. So there are various size parameters, and our guidelines and recommendations are based around that. But unfortunately, we do not have a very accurate way of measuring the size of neoplasia. So we desperately need to develop a system to measure. This is what we did in collaboration with NEC. We created an artificial pig model, and within this colon, we created accurately measured polyps, which were perfectly sized. Here you can see that in action. So AI finds this polyp, measures it, and tells us this is category B polyp, which means it is more than 5 millimeter in size. And if you look at our data here, we compared these polyp sizing with AI, which was accuracy was 85.2% as compared to 59.5% for the endoscopist. And this difference holds true for both less than 5 and more than 5 millimeter polyps. Now, if we go to real-time sizing, here is an example of a real-time sizing. This is a polyp around 10 millimeter in size, and you can see AI is sizing it as category B, which is polyps more than 5 millimeter in size. If you look at this, this is a very tiny polyp, and AI is sizing it as category A, which is less than 5 millimeter. Let's not play this again. Let's move on. So in conclusion, I think AI-assisted sizing is a real possibility, and this will influence the management and help us introduce strategies like resect and discard, resulting in huge health economic benefits. I'll stop here and take any questions, but would like to thank my colleague, Dr. Mo Abdul Rahim, who did a lot of this work with me, and would like to invite you all to join us for Portsmouth Live in January. Thank you very much.